Welcome, everybody, as you get settled. It's good to see everybody from the community. We have a lot of people today, so thank you very much for coming today. Um, Today's topic is, I think, a really important on. There's such an uptick today. I don't know if you agree, or put in your chat bar if you agree, that how many of you have seen since COVID has dragged on for over a year, that one of the things that we're seeing is more and more kids with anxiety problems, but also, yep, more, Don says yes, okay, but also more and more kids with threats of suicide, um, and more out of control behaviors, okay? And Wayne says so much so. So I have seen that too. And I want to approach this problem from looking at it from a family systems lens, because I know when I got first started in my career, I looked at suicidal ideation more from an individual lens, where I'd work with the child. I worked at hospitals, alternative schools, but I really didn't see it as much from a family systems viewpoint. And I want to share with you some of my research on what fuels suicide ideation for children and adolescents through a family lens, and get your input as well. And then I want to give you a tool that we found called the Safety Stressor Questionnaire, which allows a very low level, non-threatening way to bring up suicide to talk about. Because the other thing I saw with suicide was that that we really see secrets around suicide, and that many families don't want to bring it up or don't know how to, just like abuse or neglect. And so we've got to get a way to bring this out to the surface. So with that, let's get started. We're going to go 20 minutes, just a little bit of Q&A with kind of an overview with some slides, and then get time for questions as well. So thank you for coming again today. Appreciate it very much. So I posted on our community this question, family secrets, that this is a driver for suicide gaining strength like a hurricane. How many of you have also seen, like me, that secrets can kill, literally? And so we've got to find out a way how to bring these out in the open safely, so it doesn't scare the family, where they won't come back. And so that's the tool I want to present today. For those of you who want to go deeper in this area of family trauma, each month I do a more intensive 1 hour webinar for free. And then this next month, June 16th, please save the date. This is another big one, technology addiction. That has gotten out of control. I know we're struggling with it in our family. We have two 12-year-old twin boys, David and Jonathan. And since COVID has hit, this has actually been amplified as well. So I want to just save the date on that, and just go to familytrauma.com after today or anytime you want to, and register live or on demand. So what I'm going to talk about is from a 10-year research project that was published in this book, Treating the Traumatized Child, with my colleague, Ellen Souter. It pivoted off of the book to become the Family Trauma Institute, where my goal is every Friday I'm going to do what I call family systems trauma Fridays or solutions, because I really want to help bridge the gap with our community to go from the individual that's traumatized to the entire family that's traumatized. I really saw when I began this work that there was a gap here, that there was tons of stuff on working with the individual, but not so much step by step to bridge the gap to work with the whole family. So that's my contribution in a humble way, is to help people become an expert of family trauma. So there's 12 core techniques that came out of this research. And I want to focus today around suicide, around the just an overview of number 3, the stress chart. I mean, number 4, the C tree diagram, and number 5, stabilization versus active trauma work. So this webinar is going to focus on one method of treating adolescent or child suicidality. Now, remember, there's many different models for suicide, and they're all good. So I see this more as both and. I was taught originally in cognitive behavioral or trauma-focused CBT, but I want to present this idea of that look at this problem from a family systems trauma lens. And so that's kind of where I'm going to focus my attention on today, but not to say other models are good or bad. This is more of a both and approach. So I see a canary in the coal mine, and I like metaphors if you get to know me, and parallel processes. I see that the canary in the coal mine from the miners in the old days had a canary to see if there's gas that you can't smell or see. The canary would stop singing and the miners would get out of the coal mine quickly. So here's what I'm seeing. Some stats are worrying me, and I don't know if they're worrying you as well, but emergency room visits for suicide attempts or ideation have jumped. So from 580,000 in 2007, and this is within the United States, I don't have stats from other countries. They've risen in 2015 to 1.1 million. Now, this is before COVID hit. So this worries me that it's almost doubled. And this is really concerning me. 43% of those visits are happening with children younger than 11. How many of you have seen more and more suicidal ideation from younger children? Are you seeing that? So this is telling me that we've got to look at this issue here because it's starting to get out of control. And so my takeaways today with you guys as part of our community is looking at this from a family systems perspective. And then this is the tool I want you to leave with today. I'll post these PowerPoint slides on our community after this is over, so you can get this and download the tool from the PowerPoint slides. But the safety questionnaire, an ideal beginning. So let's get to this issue here. I want to know from you, if you wouldn't mind though, before we jump in, what's a reason why you think today teen suicide is so difficult to treat? What is a reason why you think it is? And I'm going to call on some of you too. So Dawn, I see you. It's nice to see your face today. Could you unmute your phone and tell me why you think suicide is tough to treat on our best days? If you could unmute your phone. I don't know if you can. Let's see if we can get a Z, or maybe I have to, but can you unmute it on your end, Don? Let me see. Oh, maybe you can't. Okay. All right. Let's see if Wayne, can you unmute your phone? I wanted to get your input if you would. You there? Okay. No? Okay. So let me see the chat bar here. And so Brittany writes, families are stressed as a unit, making it harder. So I would say that is right on. Technology, Dawn, you write, that fuels the fire. Dr. Andrea says social media has allowed people to vent their stress, but that leaves the family out and the professional out, underreported. Okay. These are all really, really good reasons. And Wayne says limited access to supports. Okay. So I want to share with you, these are all right on. I want to share with you from a systems point of view, 2 things here and see what you guys think about this here. So the first one is that I've seen from a systems point of view is, number one, extremities breed dysfunction. And from a family systems point of view, when I map out a family, I see that one of the extremes that fuels suicidality, is disengagement. When a family is disengaged overall, I'm worried. Now, what I mean by that is a child will say to me, I have no emotional connection. My parents don't even know what my grades are. They don't know where I am at night. Um, I have to almost threaten suicide before they'll even notice me. Now, I've actually had kids say this. So when there's a lack of attachment and there's emotional disengagement, that's an extreme. Now, this is less known. The other extreme is enmeshment, where the kid says, I am smothered. There's no boundaries. I can't even move in this family. And sometimes kids will be like, I just need to threaten suicide just to get people off my case, to say, I'm out of here. And so what kids will do a lot of times is that they will solve problems in creative ways that aren't very helpful, but they solve those problems. And one of those is threats of suicide. And what happens with kids is they're so impulsive and their brains aren't developed that their judgment is clouded. So many kids who die by accident because of impulse. So I take suicide, whether it's a manipulative way of getting what they need or an emotional. Kids today are more vulnerable because they could accidentally kill themselves. So how many of you agree by putting yes in your chat bar that you have seen these extremes systemically, and that they can definitely breed an environment of suicide? So yes. Okay. So Brittany, Rupa, yes. All right. So from a structural point of view, in the old days, I didn't see the family dynamics of suicide. I would just see the child's depression, their negative self-talk, and that's what I would primarily treat. But when the child will go back to the same environment of disengagement, if I didn't help solve that problem, it would fuel the risk of suicide. So that's number one. When you're assessing a child, a tool you can pivot off of this short webinar is there extremes in disengagement or enmeshment? If there are, it breeds an environment of suicide. Not necessarily, but it's a risk factor. Okay, let's go to number two. Okay, the second thing that I see from a family systems viewpoint is this one. And this goes into the story of AJ. So AJ comes to me and I'm in the role of consultant. And AJ's 15 years old and he lost his father at the age of 4 to a shooting. And his mom was a young mom and said, I can't raise him. Will you raise him, the grandmother or the mother of the son, the father that was shot and killed? So AJ is 14 right now. He's been in and out of therapy for many years. And everybody assumes that the grief is healed because time heals all wounds, doesn't it? The problem is grief hasn't really been brought up, but they think he's over it because he's not talking about it. That's a problem. The other thing is what was said in the chat bar is he's steeped right now in technology addiction to the point that he's also has a relationship with a girl across state lines through Snapchat, who he's exposing himself and things like that. So that is being dealt with now. But what has not been talked about or never asked is has AJ ever thought about suicide? Now, you would just think that that would be common sense, but I'm surprised a lot when I come in as a consultant how these basic safety issues are either glossed over or assumed by the family or therapist as, we don't need to even deal with it because it's been addressed or not even asked. So one of the tools in the FST family systems trauma model as you get to know this model more, if you stick with it, is that we use metaphors and visuals to bring out secrets and allow the family to be the co-detectives. So in this family, I came in through telemedicine as a consultant, and we put all the stressors on the apples of a tree and said that this apple tree represents like a family that's stressed out. And if you're an apple doctor and you look at the apples and they have bruises or worms on them, one of the things that we want to get to is what's underneath the soil. What can't you see with the naked eye? And this apple tree draws the family in because you can draw it on a flip chart. You can put it on a PowerPoint slide. And what happens is it's called externalizing the problem. It shifts the focus away from just fix AJ to a family solution to let's be co-detectives and look under the soil and see what are the undercurrents that are driving the symptoms. And I'll even say, like a medical doctor, you would look at blood work to determine where the virus is. An apple doctor is going to look at the roots to determine why the apples keep turning brown or, stressed. So this family gets excited because we hand them out a handout that they get to pick their seed. Now, I know it's subtle, but it's called externalizing the problem. Now the seed and the undercurrent is the problem that we've got to solve, not fix AJ. And so with suicide and other issues like depression, this is a golden nugget for us as mental health workers, because we want the family to be the co-detectives. So when the family gets this handout, I say to them, this happens in families, and your job is to pick out the one that you think is driving the problems. I say unresolved grief or loss. AJ raises his hand and says, yep. And I said, my job as a coach or therapist to fill in the missing healthy undercurrent, which is grief, education, and resolution. Do you have betrayal or abandonment that's fueling the unhealed wound seed? Do you need forgiveness or unconditional love? Nope, that's not an issue for our family. Family secrets, yes, but we don't really want to talk about it yet. I said, well, my job is to reveal the secret safely. Is there physical or mental abuse? No. Is there lack of forgiveness or bitterness? No. Is there lack of consistent nurturance? I said, these allow me to go from trauma informed to trauma responsive. I want to get to the root of the apples. Now, the family reveals that there's a secret, but they won't tell me what it is. But the sheer ability to go from the apple tree to the undercurrents allows families to really enjoy the process. And then I'll take questions at the end about this as you have them. So write them in your chat bar as we go along. So the first one, from a family systems point of view, that fuels a suicidal environment is extremities around disengagement versus enmeshment. Number two, the therapist doesn't always have a onboarding set of tools to gently and tenderly move the family and their own thinking to the root. They stay in the weeds. They just pull weeds. I don't know about you, but I'm in the business of going into root work. And so the undercurrents help and they allow us to know where to tap. So here's the next technique I want to do to go from trauma informed to trauma responsive. So I know there's secrets, and sometimes the families won't even tell me their secrets when they get this handout. So here's the technique I want to show you, and then you can use it to try it out, see what you think. So the conundrum that I was facing was, oh my gosh, how do I bring this up? It's scary for me. If I do it badly, it's like a red herring and the family won't show up again. Have you ever had that feeling when you know you got to bring up these secrets, but you know if you do it badly or clumsy or awkward, that the family will get scared and you'll lose them? Has anyone else felt that way? Okay. All right. So when we talked to the families in that 10-year research project, we were saying, how can we bring this up? I'll never forget this story. I was working 8 sessions with this family. I don't know if this has ever happened to you, but by session 8, I start to find out that there's suicidal threats. And I asked the parents, why am I finding this out after 8 weeks? And the parent looked at me and said, you never asked. That was so eloquently stated. And I was like, yeah, I never have asked. So early on, after I give the seed tree diagram and they identify the undercurrents, I transition to this statement. Now that I know some of your undercurrents, I want to make sure that we go through safety issues. And you say, I do this with every family. It's standard operating practice. So I found that the best time to bring up these safety issues is at the beginning of treatment. Families have told me that as long as it's like standard operating practice, it takes out the stigma of like, you're going to talk about secrets now, but if it rolls off your tongue and it connects to the seed tree diagram, it makes the transition smooth. So let me show you how this is done and see what you guys think. This is messy. It's not easy, but if you don't do it, who will? Let's go through this. So, do you agree that family secrets is a huge issue? I think we've talked about the answer is yes. We've got to bring it to light. So, this is an ideal beginning. Now, I'm just going to give you a broad stroke overview of this. There's more involved, but because of time, I'm not going to go deep into it. But I want to give you kind of a taste of what it looks like. So here's the transition sentence. One of the things I'm most proud of when I wrote the book, this is my 3rd one, is that I wanted to create a book that had the actual script in it. I got tired of reading books that just had generalized principles. I wanted to become like a good actor has a script when they're introducing techniques. When I would read books and they didn't have scripts, I was lost. So I have transition statements before each technique that you guys can use when you're introducing the technique. So I say, I will pass out this handout of safety stressors. I'm going to ask each of you to vote yes or no. If yes, I'm going to put it on this stress chart to address later. Now, look at this safety stressor questionnaire. One of the key things is that we don't ask yes or no questions. When we would ask, a sentence, is there self-harm, yes or no? The answer would be no. But if we bring this safety stressor questionnaire and we ask questions like, when was the last time? How often? Is there a plan? What is the plan? In the context of other safety stressors, it starts to bring out not only suicide, but things like bullying. When was the last time you cut yourself? Now, this is a game change. This was a game changer for me and colleagues I worked with, because the families, in AJ's case, for instance, the grandmother said to me, after you pulled out this technique, you won me over. I said, why, Robin, did I win you over? And she said, I knew you knew what you were doing, because I've been to counseling with my grandson, but you had the courage to bring this up. You brought it up very smoothly, non-threatening, allowed my grandson and me to talk about these issues. And I knew that you could handle the good, the bad, the ugly. And you'll get that from families. They want to know if you can handle this stuff. And so the process delivery tips I want to give you is 3 of these. As you know, a technique is sometimes only as good as the delivery. You can have a great script as an actor or actress, but great actors and actresses also have directors that say, I want you to deliver this with excellence. It's not what you say, it's how you say it. So before I hand this out, and before I handed this out to AJ's family, I gave number 1, and you could take notes or just remember this. I said, we're going to get into something called safety first. And I want to forewarn you that this may open up a can of worms, or other people have said Pandora's box. And what I want to share with you is that this is normal, that we have to get this on the canvas. We have to get this on the table, because if there's safety issues, we could cause harm to self or others. Number 2, I want to set clear expectations in what my role is. I'm going to ask your permission to interrupt you, cut you off, because right now we're just beginning during this diagnostic and assessment phase to bring out the issues. Later, we'll go in depth. But when somebody brings up a safety issue, especially if it's a family secret, you're going to want to talk about it now, and you're going to talk about it in depth. Timing is everything. This is not the right time. I know you'll want to, but if we open this up too fast, it'll blow it up. So I say, expectation number 1, do I have your permission to say time out, stop, and interrupt? That's my role. The other expectation is you can pass. If I ask you when was the last time you cut yourself and you don't want to answer that question, you can say pass, and that's fine. You're not ready to talk about it right now. And I want to set some clear boundaries. There'll also be an expectation on the drive home, or when I leave this home visit, that you're going to say, okay, now that he's gone, I want to know everything about this secret. No, don't do that. Here's why. You need an expert to help you through this. And if you blow the doors up and the person feels that you're pushing them too fast, you're going to lose everything that we've gained. So do you have clear boundaries? So these are the boundaries that I put down before I give this. Now, even with these Surgeon General warnings I'm giving you, it could still blow up. But the risk goes down because of the methodical and systematic way that you're doing it. You're not just saying, oh, here's a handout, let's just talk about this hurdy-gurdy. You're doing it slow and respectful. And that's exactly what happened with AJ's family. He was able to feel safe to bring up, yes, I have threatened suicide. I have grief issues that have not been dealt with. And that's why the family felt safe, because they could bring it up safely. So these were the takeaways today. And before we get to questions, and Allison will field these for me, she's helping me today. I want to share with you that next week at 1:30 Eastern time to 2, not to 2:30, I'm going to be doing Family Trauma Solution Friday on anxious kids and anxious families. with our community exclusively. And I just as kind of just a foreshadowing of things to come, I'm going to be talking about anxiety problems. In this case, as an example, phobia. But I want to get into the symptom, but I want to get into how more than ever parents are over accommodating and not allowing children to go through anxiety. And we're going to talk about, is it an active participation or a lifestyle change by the family? So if this topic interests you and you're seeing a connection of over accommodation, please come and tell your colleagues. So if you want to go deeper, just please check out familytrauma.com, and you will see that you can go deeper on a 3-hour CE on a special topic like disrespect, or you can check out the course that I offer twice a year. That's a 14-week course that goes through every technique like I'm doing today. We talk about the topic and we see a case example. So there's a short video if you're curious under this one to kind of see what the course is all about. So with that, let me ask Allison if there's some questions that came up today or comments about this important topic. Allison, are you there? You got to unmute yourself there. Okay, she's having some technical difficulties. So let me tell you a common question I do get and give you time if you guys have any questions here. The first question I typically get is, what happens when you give the safety stressor questionnaire and the family basically says, I want to pass, but they know that the issue is on the table. So here's what happened to me. I'll give you a story. So one family came in and the adolescent had a sweatshirt on, and it was the middle of August. Right away, that gives you a sense that there could be self-harm or cutting. So when I bring up the safety questionnaire, he looks at me with an evil eye. He knows what's coming and he's not happy with me. So when we get to the question, when was the last time you ever had feelings of wanting to cut yourself? He said, get the F out of my face. Move the F on. Now the mother immediately goes to the boy, adolescent, and says, that's a good question he asked. In fact, why are you always wearing sweatshirts in August? I cut her off immediately. He said, remember what I said earlier. I respect the boundary of him wanting to pass. She goes, no, I block her. Hold on. If you keep asking him, he's going to go into a shell, and I respect his right. Right now, he doesn't want to say, and I don't know if he's even doing it. Then I quickly stuck and moved on. Now that adolescent later on asked me and said that was a turning point for him because nobody had stuck up for him. Later, he does reveal the self-harm. But if I had not taken control of the session there and backed up what I said, I would have lost the family. So that's a common question, is that you've got to be directive. This model is a model of action. You know, sometimes I was taught in school just to let people talk. And in some contexts that works. But in this context, when you're revealing the safety stressor questionnaire, it doesn't work because people can go on and go on a bunny trail and unravel what you just did. So, so any questions you guys have before we head out? Any others? Let me see. Okay, so if you weren't able to ask your question, oh, I got one coming in. Please just post it on our page after this one, and I'll answer it. But Brittany writes, with this being a family model, how do you negotiate with children who do not want their families involved with mental health, particular teens who do not want their family in therapy? Well, you have to start where the client is, and sometimes that happens. So I negotiate with the families, like I'll just work with the child, and then of course I will also say the limits of my confidentiality to the child, that if you reveal homicide or suicide, I have to report. So oftentimes it's an area of trust where I'll say to the family, look, here's the limits of what I can do. I will start with where you're at, but I will circle back around with you and say, here's what my limits are. And sometimes when you start where the client is and where they see competency, you have room to negotiate different terms of therapy. So that was a great question, by the way. So, okay. So thanks for coming today, guys. Just enjoying getting to know everybody on the community. Next week is on anxiety. And yeah, so post your questions or comments, and then I'll get a chance to answer them this week. So have a great weekend, everybody. I'm enjoying getting to know everybody. Take care. Bye, everybody.